So a couple of things to discuss today. The first is a little more about the UK SARS-CoV-2 virus variant that we discussed last week a bit. I think some additional press coverage has occurred in the interim, and also apparently some questions about whether the current UK variant could explain the surge in cases that we had in the Midwest earlier in the fall, or whether that's explaining any of the activity we're seeing in California or other places now. So if you remember, this new variant has a number of different mutations that make it different from other viruses that have been seen, especially since these have occurred together, apparently at the same time with this new variant. It's started in the UK, but now has been detected in a number of countries, both in Europe and now outside of Europe, and you can see Canada has also detected some of these variant strains. We have not yet detected this variant B1117 in the US, but as you can see, our rate of sequencing viruses is about 25-fold less than what the UK is sequencing. So they are sequencing a large proportion of their viruses that they detect, whereas we are not. And so it is certain that this variant is in the US and may be circulating in communities, probably those that have stronger connections with the UK and flight traffic that comes in from the UK. And so that's going to be in the New York area, primarily Chicago, LA. But I think it's unlikely that this new variant has affected any of the epidemic transmission that's going on currently in the US for a number of reasons. First of all, we don't really know how much more transmissible this virus is than its previous wild type ancestors in the UK. Certainly some of the epidemiology of recent transmission in and around London and the southeast of England, where this variant predominates now, indicates that transmission rates are higher there. But it's also true that in the UK's double hump fall wave, the earlier surge of cases that occurred mostly in the middle of the country and then the north, so Birmingham, Manchester, etc., did not have a predominance of this virus. In fact, very few cases of this variant were seen in that hump here. They've only occurred lately, where the surge has been centered in London and in other parts of the south of England. So this could be, and it is very similar to what's happened in the US, where you had, we had a larger surge in the Midwest that started the fall wave, and now that's subsided somewhat. And now we're seeing surges more predominant on the coasts, in the West Coast and East Coast, and in the South. As you can see here, this variant was first detected only in late September, and that was after our surge started here in the Midwest. And only predominated in London, very recently. As you can see, still in the middle of November, there were still only 25% to roughly a quarter of UK isolates were this variant. And it's not until recently that greater than 50% have been seen. So the timing and the pattern of transmission just don't necessarily fit for this virus to have made an impact in the US so far, even if it is significantly more transmissible, which again, we don't necessarily know. And again, this was a slide that I showed, I think, last time, but as you can see, it's really not until December that we start to see a significant proportion of virus isolates from the UK contain this variant. And in late December is really when things, after the 15th or so, start to again be predominantly more than 50% this virus. So it may be that we're affected by this new variant moving forward. Again, I think it would be highly unlikely and statistically miraculous if we didn't already have many of these strains already introduced, imported through UK travelers, which there are quite a lot of coming into the US in and out every day. And so we'll see if that has any effect on transmission rates going forward. But I think up until this point, probably very unlikely that there's been any impact. The other thing that I thought was a good thing to touch on was an article that was published in the New England Journal recently looking at healthcare workers and the risk of reinfection, which was the most important part of this study. So this study was in the UK and looked at healthcare workers who were seropositive, so again had antibody tests that indicated previous infection versus those that didn't. You can see that this was assessed in March and April, and at the time they had a cohort of about 1,200 healthcare workers who were seropositive, so evidence of previous infection, acquired in the spring wave, and about 11,000 who were seronegative, and then followed them over 6 months until November. A couple of interesting things. I think it's important to note that a not insignificant number of those seronegative healthcare workers actually had documented evidence of PCR positive COVID, 0.2%. So indicating that not all people who get infected, even acutely, so obviously in England at the time, that had to have been infection within the last 3 months. And still there were a number of those who were seronegative. So we know that seropositivity is not necessarily the end-all be-all of determining who was previously infected, and again may indicate some lapses in immunity. But I think it was comforting to note that people who were seropositive at the time had a much lower rate of documented infection. Only 2 out of the almost 1,200 had documented infection after that. And you can see on the right, that's a curve comparing the seronegative to seropositive healthcare workers, showing that seronegative people, again, those with at least without evidence of previous infection, had an infection rate over that 6 months, which was roughly 6 times higher than what was seen in seropositives. But that also means that there were a couple of cases in those seropositives, 2 out of 1,100. And given the small-ish number, a pretty wide range of what the incidence would be, comparing or looking at people who've had detected antibodies and are seropositive, and who can be reinfected. So again, just I think reinforces some of what we already knew, that there is certainly seems to be some significant protection from previous infection, but that protection is not perfect, and how it correlates with antibody levels remains to be seen. But clearly people, even with recent infection, can have low or undetectable antibody titers after those infections. So that's all I got. Thanks, Shelley.